this intestinal mucosa, and the maternal antibody doesn't interfere with the take of the vaccine. So BCG and OPV are exception to these maternal antibodies. So live attenuated vaccines, low dose can be given, single dose is sufficient, and when injected into the body, it replicates in the body and infects the host but doesn't cause disease, and it provides protection against the disease. Kill vaccines, they are prepared by growing bacteria or viruses. They are killed. The pathogens are killed by heat or formalin chemical inactivation, and the repeated doses of the kill vaccines are to be given for protection. And the other vaccines are toxoids. The toxoids are the modified toxins. These are diphtheria toxoids, tetanus toxoids, etc. And subunit vaccines are part of the pathogen is taken, like capsular polysaccharide protein component is taken, like Haemophilus influenza vaccine, pneumococcal vaccine. These are the subunit vaccines. Live versus kill vaccines. Live vaccines, low dose can be given because the pathogen is going to replicate in the in the host. So low dose is also sufficient for live vaccine. But in kill vaccine, high dose is to be given. Immunity it provides longer immunity, live vaccines, and shorter immunity by the kill vaccines. Booster needed, booster infrequently. So if single dose is also sufficient for live vaccine, but in kill vaccines, frequently you have to give the booster doses. Frequently you have to give the vaccine. In live vaccine, the stability of antigen is less. In kill vaccines, stability is more. So what is an ideal vaccine? Ideal vaccine is that which is easy to produce in a well-standardized preparation, easy to administer, not produce disease in a host. It produces infection but doesn't produce disease in a host, induce permanent immunity and free of toxic substance, and there is minimal adverse effect. These are the components of an ideal vaccine. So this is important. What are the types of vaccines? So what is BCG vaccine is live attenuated. Which are the live attenuated vaccines? BCG, oral typhoid, OPV, oral polio vaccine, measles, MMR, varicella, rotavirus, yellow fever, Japanese encephalitis, cell culture derived Japanese encephalitis vaccine. Kill vaccines are inactivated by heat or chemicals, and kill vaccines are DTWP, means diphtheria, tetanus, and wholesale pertussis vaccine. Typhoid, wholesale kill vaccines. Typhoid injectable is kill vaccine, and oral typhoid is live attenuated vaccine. And injectable polio vaccine, rabies is also killed, hepatitis A, inactivated influenza vaccine, Japanese encephalitis. There are different types of Japanese encephalitis also. Some are live attenuated and some are killed. And the toxoids are diphtheria and tetanus. This is very important. So BCG is live attenuated. For you, important is BCG, live attenuated, oral polio, live attenuated, measles, MMR, live attenuated, varicella, rotavirus, live attenuated. Killed are DPT, injectable polio, rabies, influenza, JE vaccine, toxoid, diphtheria, tetanus. Subunit vaccines. These are the toxoids, means modified toxins. Toxins of the these diphtheria, tetanus, they are detoxified and they are they are kept in the vaccine. Subunit is part of the pathogen is taken, like hepatitis B is a subunit vaccine, acellular pertussis, DTWP, wholesale pertussis is kill vaccine, but acellular pertussis is subunit vaccine because part of the pertussis component, part of the pertussis pathogen that is taken. Capsular polysaccharide are Haemophilus influenza, pneumococcal, meningococcal are capsular polysaccharide. These are all subunit vaccines. Conjugated vaccines, these are like The component of the vaccines that like in Haemophilus, meningococcal, pneumococcal, capsular polysaccharide. These are the capsular polysaccharide vaccines. So here the protein is added to increase the immunogenicity. Polysaccharide antigen, capsular polysaccharides, they are T cell independent. They are only B cell dependent. They work for B cells only. So they are not given in children less than 2 years age. They are not they are not efficient in children less than 2 years. So when they are mixed with protein, when capsular polysaccharide vaccines, they are conjugated with protein, it increases the immunogenicity of the vaccine. It provides B cell and T cell immunogenicity. So these are preferred for children less than 2 years. So we'll talk about this, which are conjugated vaccines. There are later on. The efficacy of vaccine. There are primary vaccine failure and secondary vaccine failure. So when you give a vaccine and if it is not able to induce an immune response, it is primary vaccine failure. And if it is able to produce immune response but it is not able to protect from disease, it is secondary immune response. And we mostly see primary vaccine failure with oral polio vaccine and secondary vaccine failure with pertussis, typhoid, BCG vaccine. The storage of the vaccine. Normally, we store most of the vaccines at 2 to 8 degrees centigrade. Certain vaccines are sensitive to freezing temperatures because they contain an aluminum adjuvant like DTAP, DT, TD, TDAP, HIV, hepatitis A, B, rabies, pneumococcal, HPV vaccine. They are sensitive to freezing temperatures. And the other vaccines, MMR, varicella, typhoid, yellow fever, lose potency when exposed to increased temperature because they contain live viruses. So this is an example how the vaccines are kept in a freezer. Then in the freezing compartments, we keep ice cubes, OPV vials. OPV vials, they are kept in the freezing compartment. And in the top compartment, we keep BCG, measles, in the middle, DPT, DT, TT, typhoid, hepatitis A, hepatitis B, varicella, and diamonds are kept in the lower compartment. In the freezing compartment, we keep OPV vials, and the rest we keep in the middle compartment. These are how the vaccines are stored. So this is very important. So after the birth of the baby should visit for vaccination to the hospital or health center at birth, 6 weeks, 10 weeks, 14 weeks, 9 months, 12 months, and 15 months. So there are 7 visits to the health center for immunization. So at birth we give BCG, that is given intradermal. That is protection, that is for the protection of tuberculosis. At 6 months, at 6 weeks, 6, 10, and 14 weeks, we give pentavalent vaccine. They are DPT. Pentavalent means 5 vaccines. It comes in one vial. This is DPT, hepatitis B, and HIV. So we give this at 6 weeks, 10 weeks, and 14 weeks. And recently, rotavirus is also added. It is about 1 month. That is given at 6 weeks and 10 weeks. Pentavalent vaccine is given intramuscular, while rotavirus vaccine, this is oral. This is given orally, 2 drops. And polio vaccine, we give oral polio vaccine and injectable polio also. Oral polio vaccine is given at 6, 10, and 14 weeks. Injectable polio, this is called IPV, injectable polio vaccine. This is given at 6 and 14 weeks. And PCV vaccine, pneumococcal vaccine, is given at 6, 10 weeks, and 9 months. So at 9 months, we give PCV and measles rubella MR vaccine. MR is given subcutaneous, PCV is given injectable. And Japanese encephalitis is given at 12 month, and MR is given at 9 month and 15 month. So BCG at birth, this is very important for you. You should know this. This is the national immunization schedule. So BCG at birth, pentavalent vaccine at 6, 10, 14 weeks. Pentavalent means DPT, hepatitis B, T vaccine. Pneumococcal vaccine at 6 weeks, 10 weeks, and 9 months. Rotavirus 6 weeks, 10 weeks. OPV 6, 10, 14. IPV 6 and 14 weeks. And MR 9 months, 15 months, and JE at 12 months. So among these, BCG is given intradermal. Oral polio vaccine and rotavirus is given orally, 2 drops. And IPV is given injectable. Injectable IM, and DPT, the pentavalent vaccines, are also given IM. And JE, MR, they are given subcutaneous. So this is also the same. And all the vaccines, they are 0.5 ml, except BCG, which is 0.05 ml. So sites of the vaccine administration. So all the vaccines dose is 0.5 ml, except BCG, which is 0.05 ml. Then they are administered intramuscular, subcutaneous, or intradermal. For less than 18 months in intramuscular, less than 18 months we give in anterolateral aspect of thigh. For toddlers, anterolateral aspect of thigh or deltoid. For adolescent, young adult, we give in the deltoid. The insertion of the deltoid. The sites of administration, this is the anterolateral aspect of thigh. This is the deltoid. In the insertion of the deltoid, we are giving the intramuscular vaccine. So intramuscular vaccine, this needle is injected at 90 degrees to give the intramuscular vaccine. For subcutaneous, needle is injected at 45 degrees, and for intradermal at 0 degree. So intramuscular, anterolateral aspect of thigh in infants and deltoid in older children. For more than 2 years, we usually use deltoid for older children, and it is not given in gluteal region because it can cause sciatic nerve injury. Diminished immunogenicity of hepatitis A and rabies virus is given in gluteal region. So it is safer to given in the anterolateral aspect of thigh or deltoid. Subcutaneous, it is given at 45 degrees. So the spacing, these are the principles of vaccinations. There are the principles which you have to know of different vaccines. And 2 kill vaccines, more than 2 kill vaccines, they can be given at the same time, any interval or simultaneously. They can be given at the same time also. If you are giving live and kill vaccine, then they can also be given at any interval or simultaneously. If you are giving 2 live vaccines, then at least 4 weeks interval should be there. Some live oral vaccines, OPV, typhoid, rotavirus vaccines can be administered at any interval before or after live or inactivated parental vaccines. OPV and rotavirus, these are given simultaneously also at 6 and 10 weeks. So this is an exception. Otherwise, you should maintain a duration of 4 weeks in between the 2 live vaccines. This is the principle of vaccine. 2 live vaccines, if you are giving, there should be 4 weeks duration. If live and killed, then it can be given at the same time or at any interval. If 2 kill vaccines, it can be given at any interval or simultaneously. And if a child has mild fever, diarrhea, upper respiratory tract infections, these are not the contraindication of the vaccine. You can give vaccination if there is mild fever, diarrhea, upper respiratory tract infection, etc. And recent exposure convalescent phase of illness, recent exposure to infectious diseases, current antimicrobial therapy, these are also not the contraindication for the vaccine. But if you are giving live vaccines, then these are contraindicated in immunosuppressed patients. If the patient is taking high dose of corticosteroids, if there is malignancy, then you have to, then the live vaccines are contraindicated. But you can give when the steroids are being tapered, or 2 weeks after the steroid is stopped, you can give the live vaccines. And if a dose is missed, then you don't have to repeat the whole schedule of the vaccine, while you can give the missed dose. So prematurity is also not the contraindication. You can give the vaccine if there is family history of adverse effect to immunization, mild to moderate reaction at previous site, prematurity, malnutrition, history of allergies. These are not the contraindication of the vaccines. So what is hard effect? We get hard effect after giving oral polio vaccine or measles vaccine. So this is when a certain number of people are immunized with the vaccine, and then the unimmunized population also gets the risk of disease in the unimmunized population is also reduced. That is herd immunity. By protecting an adequate proportion of susceptible individuals with an organism by simultaneous vaccination, the transmission chain is broken. And this diminishes the risk in the unimmunized population also. Like in case of oral polio vaccine, it reaches to the intestinal mucosa and it multiplies in the mucosas, and it protects the immunized as well as the non-immunized population by the herd effect. Now talking to individual vaccines. The first BCG vaccine. BCG, it was developed in 1921, and it has a strain. You should know the name of the strain, that is Danish 1331, and it provides immunity against a natural infection. It is multi-dose vial reconstituted with sterile normal saline. It is reconstituted with normal saline, and the dose contains 0.1 to 0.4 million live viable bacilli. It is live attenuated vaccine, and there are the organisms which are attenuated, with the effect of the organism is potency is attenuated, and that is kept in the vaccine. The protective efficacy is for miliary tuberculosis, and this is also very important for you, for miliary TB and tubercular meningitis. So the protection is 80%, and for pulmonary tuberculosis it is only 50%. So it is stored at, most of the vaccines, they are stored at 2 to 8 degrees centigrade. At 4 degrees centigrade, potency satisfactory for several months. After reconstitution is stable for 1 to 2 weeks, but preferable to be used within 4 to 6 hours. So it is a method of vaccination. It is inserted in the deltoid. According to IAP, in India it is inserted in left arm, but in Nepal it is in the right arm, interdermal, and 26 gauge needle is used. So after vaccination, these are the normal reactions. There is, after injection, there is wheal of about, this is a reaction following vaccination, wheal of about 5 millimeter, and by 2 to 3 weeks it increases to it develops to a papule, and by 4th week increases in size 4 to 8 millimeter, also raised by 6 to 12 weeks, and yields by scarring. So if a baby after BCG vaccination, it comes with a papule or ulceration, you don't have to worry, it will improve by itself. This is the normal reaction following vaccination. So PPD becomes positive if tested. The tuberculin test, if it is done, it becomes positive if tested 4 to 12 weeks after immunization. The BCG vaccine, it is given at birth, and if that is missed, it can be given till 1 year of age, that is catch-up catch-up vaccination. So these are the normal reaction following vaccination. This is normal. This process is formation of papule, ulceration, scarring. This is normal. But what is the adverse events following vaccination? So if there is accelerated reaction in tuberculin post, local ulceration or discharge in sinus, these are the adverse effects: discharge in sinus, axillated lymphadenitis, disseminated infection, osteomyelitis, scrophulodderma, keloid formation, etc. This can happen after vaccination, and for these you have to visit a doctor. So if a mother is tuberculosis positive and gives birth to, if mother is tuberculosis positive and gives birth to a baby, then you should give BCG vaccination at birth, and I should start isoniazid 10 mg per kg per day, single dose for 3 months, and you have to repeat man-to test at 3 months, and if it is negative, then BCG vaccine should be repeated. So this is how you give BCG vaccine to a child born to a mother of with active tuberculosis. So there was another test called BCG test. What is that test? It is done. It was done in for diagnosis of tuberculosis, congenital tuberculosis previously, but it is not done nowadays. This is accelerated response after injection of the vaccine in individuals suffering from tuberculosis. If patient is suffering from tuberculosis and if you do BCG test, then there is accelerated response. There is in duration of more than 5 to 6 millimeter after 3 days of BCG vaccination, and that is considered positive reaction for positive BCG test. But this is not frequently done nowadays. Next, DPT. So this is given at 6, 10, and 14 weeks. There are different terms like DTWP. This is DTWP, that is diphtheria, tetanus, wholesale pertussis. DTAP, like diphtheria, tetanus, acellular pertussis. In DTWP, diphtheria and tetanus are toxoids and wholesale pertussis is taken. In DTAP, diphtheria and tetanus toxoids and part of the pertussis component is taken, like detoxified pertussis toxin combined with filamentous semaglutinin, fimbrial proteins, portactin. These are the components of the pertussis. These are taken in acellular pertussis vaccine. So, with DTWP, neurological complications are seen most of the time in children after administration of the vaccine. So nowadays DTAP is preferred, but in our national immunization schedule there is DTWP that is kept in the national immunization schedule. So sometimes we see patients with neurological complications after administration of the vaccine. The advantage of DTAP is superior efficacy and fewer adverse effects, equal protection, and relatively less reactogenic. DPT vaccine. This is given, the adjuvant is aluminum hydroxide and given at 6, 10, 14 weeks. So the contraindication to vaccines are anaphylactic reaction to a previous dose, encephalopathy within 7 days of previous dose of DPT, progressive neurological disorder to administer DTR. If there is progressive, if child is cerebral palsy, that is non-progressive neurological disorder, so you can administer DPT vaccine in that child. But if there is progressive neurological disorder, then this is contraindicated. And with previous dose, if there is anaphylaxis, if there was encephalopathy following previous vaccine, then these are the contraindications to DPT vaccine. And relative contraindications are, it should be cautious if there was, with previous dose, if there was temperature more than or equal to 105 degrees Fahrenheit within 48 hours, if collapse or shock-like state within 48 hours of a previous dose, persistent inconsolable crying less more than or equal to 3 hours within 48 hours of previous dose, seizures within 72 hours of receiving a previous dose, and GBS, Guillain-Barré syndrome, within 6 weeks after a dose. These are the you should cautious of administering the next vaccine. Now, uh, DT and TD vaccine. The diphtheria toxoid, there is 25 to 50 limit of population. LF means limit of population, and tetanus there is 5 to 25 limit of population in DT vaccine. But in TD vaccine, there is only 2 limit of population of diphtheria toxoid. This is the composition of the vaccine. The composition is different for TD, DT, TDAP, DTAP, etc. The DT vaccine is given for less than 7 years, and for more than or equal to 7 years, TD vaccine is given. When pertussis is contraindicated, or if there is side adverse effect following the vaccination, we give DT vaccine for less than 7 years. Now, instead of TT vaccine, also we give TD vaccine to the adult also. Tetanus toxoid, this is given at 6 and 14 weeks, and for pregnant mother, 2 doses are given 1 month apart. Tetanus toxin is also inactivated by formalin to make tetanus toxoid, absorbed into aluminum salts. Each dose of TT contains 5 limit of population of toxoid. Efficacy is 80 to 100%. So, whom do we give tetanus toxoid? If there is, if any patient or any child comes with clean minor wound to the emergency or to our emergencies, then we should take history whether previous vaccine was given. If a previous vaccine, like in case according to national immunization schedule, we give at 6, 10, and 14 weeks. So if all the 3 doses are received, and if the wound is clean minor wound, then we can. Then if all the 3 vaccines are taken, then we, if it is more than 10 years past the vaccination, if the child is more than 10 years, then we have to give tetanus toxoid vaccine. Otherwise, no need to give tetanus toxoid vaccine or tetanus immunoglobulin. If we don't know the previous vaccination status, or if less than 3 doses of the vaccines are given, then we have to give tetanus toxoid vaccine, but immunoglobulin is not recommended for clean minor wounds. But if the wound is deep wound or dirty wound, then we have to give tetanus toxoid and immunoglobulin both. If less than 3 vaccines are given, or if less than 3 vaccines were given, or if the vaccination status is unknown, then we have to give both tetanus toxoid and tetanus immunoglobulin. If more than or equal to 3 doses of tetanus toxoid were given previously, then if it is 5 years past the vaccination last dose, then we have to give tetanus toxoid, but no need to give immunoglobulin if all the 3 doses were received previously. Now, polio vaccine. Polio, this is also given at 6, 10, 14 weeks, oral polio vaccine. It's important strategy for preventing paralytic poliomyelitis. There are 3 serotypes, 1, 2, and 3. Previously, all 3 serotypes were included, but now 2 has been omitted because there has been increased risk of vaccine-associated paralytic polio, and only bivalent polio serotypes they are used. There 1 and 3 is used. There are 2 types, Sabin and Salk. Sabin is oral polio vaccine and Salk is injectable vaccine. And each dose, 2 drops, contain 10 to the power 5 to 10 to the power 6 median cell culture infectious dose, and magnesium chloride is used as a stabilizing agent. So this is vaccine by monitor. This is very important for you. It can be asked in your practicals also. So this has the inner circle and the outer circle. Inner circle and the outer circle. And if the inner circle is as dark or more darker than the outer circle, then you have to discard the vaccine. So this is normal. These are the, here you can use the vaccine, and like this, if it is as dark as the outer circle or more darker, then you have to discard the polio vaccine. The contraindication are, this is oral polio is a live vaccine. So for any live vaccine, the contraindication is severe immunodeficiency, like leukemia, long-term immunosuppressive therapy, severe HIV infection, and the adverse effect is vaccine-associated paralytic polio with oral polio vaccine. So we'll discuss the remaining in the next class. Sorry, no. 8 minutes, I know. So have you understood any question?